Let us start with case 4. An intravenous drug user has a high temperature and signs of cardiac failure. An echocardiography demonstrates tricuspid valve vegetations after a noticeable cardiac murmur on examination. The patient is started on IV penicillinase resistant penicillin right away and patient improves. So, what is the clinical diagnosis? What is the most probable or most likely causative agent? What is the pathogenesis? Which other investigation you would like to do? And what will be the treatment that you can think of? So, let us start with the first. So, it is acute native valve endocarditis caused by Staphylococcus aureus. And how we have come to this conclusion. So there are lots of clues which points towards this diagnosis. First of all, there is no prosthetic valve or any surgery which has been done. So valve or native valve. It is an acute condition presenting with fever and cardiac failure. And risk factor is also there, that is intravenous drug user. And the symptoms are also there, that is cardiac murmur. The investigation, that is echocardiography, is showing the vegetations on tricuspid valve. So these are the sufficient clue to tell you that it is acute native valve endocarditis. Now, why Staphylococcus aureus? Because Staphylococcus aureus is the most common causative agents of acute native valve endocarditis in case of intravenous drug user. So that's why we are betting our money on Staphylococcus aureus. So IV drug users are frequently affected by on right side of heart. So tricuspid valve vegetations are more common. What is the pathogenesis of this condition? So bacteria first colonizes the skin after a breach or nasopharynx after intubation or viral respiratory infection. They overgrow and evade the human defenses using a protein A. Now, Staphylococcus aureus has a protein A on its surface, which binds FC portion of immunoglobulin. Immunoglobulin G is a Y-shaped structure, so it captures the stem of that Y. So, it cannot bind with its antigen binding portion to the bacteria. It also releases an enzyme known as coagulase, which forms a fibrin coat around the bacteria so immune cells cannot reach to the bacteria. It also releases hemolysins and leukocidins, which destroys RBCs and WBCs in the human body. So that's how this bacteria establishes infections in skin or either in respiratory tract. Now, what happens that at this infection site, our first line of defense, that is neutrophils, they are drawn to this infection site. They get collected there, they start their fight, they form what we know as pus or purulent abscesses, and it causes either skin or subcutaneous infection or pneumonia. Now, people who are having this impaired neutrophil function, for example chronic granulomatous diseases, they are more vulnerable to this condition. Now, what happens once they have established infection in either skin or soft tissue or in as a form of pneumonia, the bacteria may deeply invade and reach the bloodstream. Now, how it does that? Because it has some enzymes which help in spreading them. For example, hyaluronidase, which breaks down the connective tissue, hyaluronic acid, staphylokinase, which lyses the formed clots which are formed around there around the bacteria, and lipases, which breaks down the fat in subcutaneous tissue. That's how bacteria may reach to the blood from skin or subcutaneous tissue or from lungs to the blood. Now, via blood, that is hematogenous spread, it reaches to the various organs which have blood supply. This is known as systemic infection or disseminated infection. And the commonly involved organs are the endocarditis, that is the heart, endocardium, meningitis, that is meninges, osteomyelitis, that is bone, and septic arthritis, that is joint. Now, which investigations to be done in case of suspected case of endocarditis? So we will learn in detail about endocarditis in the upcoming sessions, and especially in the streptococcus bacteria. But for now, you just understand that endocarditis is an infection of endocardium of heart. And there are two ways by which you can detect it. One is which is already given in the case, that you should do echocardiography, which will show you the vegetations. And second is you establish that infection is in blood. So blood cultures. So ideally 3 blood cultures to be taken within 24 hours, and it will show you the growth of this bacteria. So gram positive cocci in cluster which is catalase positive and Coagulase positive, will establish that it is a Staphylococcus aureus infection causing this endocarditis. Now, what will be the treatment if it is methicillin sensitive Staphylococcus aureus? Then obviously the patient which is receiving in the case is perfect, that is penicillin is resistant penicillin. But if you found an AST of from the blood culture growth that it is MRSA or methicillin resistant Staphylococcus aureus, you can start directly with vancomycin. Thank you very much for listening to the case, and I hope you are enjoying this case-based medical microbiology series. Uh, you do subscribe to the channel so that when I post a new video in this series, you get regular updates about it. Thank you very much. Bye bye.